All right, good day, guys. Welcome again to my channel. Just this is Dr. Paramount, a go-to destination for orthopedic insights and practical knowledge skills. Last week, I told you this is going to be very awesome. It's going to be very awesome. We're going to be having a conference lecture discussion. As you can see, I'm not here alone this time around. And I told you last week that this week lecture is going to be highly recommended for the students because we are going to be diverting into many aspects as far as management of fracture is concerned, as far as bones and skeleton is concerned, as far as cast production and cast making is concerned. So that's why I'm not here alone. I'm here with I'm here with two certified orthopedic technologists here with me. So I welcome you once again, Sir Ahmad, to this channel. Please introduce yourself. Let's get started.
My name is Amadi Stanley Temidokwe, a certified orthopedic technologist from University of Ilorin Teaching Hospital, Ilorin, Kwara State.
I'm Akeju Esther Imole-Oluwa, also a certified orthopedic technologist from University of Ilorin Teaching Hospital, Kwara State.
All right, thank you very much. I welcome you all to this channel as we'll be navigating through some aspects today. And I believe our guests are ready to receive us this afternoon to take us through some journey as far as management is concerned in related to orthopedic setting and in related to fractures and related to some dislocations and joints in the body. Then what are the latest means, the latest way of managing fractures? What are the conservative way of managing fracture in the modern days now? How do we manage fractures without using POP, without using scotch cast or fiberglass? So, without wasting much of the time, I'll be giving some questions to our guests, and they will be doing some justice to them by explaining everything to us so as to get a proper knowledge and to get the proper understanding. So, if you are a student trying to bring some things out of orthopedic cast technology, this is a right channel for you. And if you are also if you're a technician or if you're a technologist trying to navigate through some basic knowledge about fracture management, casting procedure, and the knowledge that you need to get, so this is for you. All right, so now I'll be having some questions that will be given to our guests so as to get us onto the track. All right, the first question will go to Miss Akeju. Can you explain the concept of two fractures? There are two fractures on a particular bone. The bone is humeral bone, humerus to be precise. Now, there's a fracture at the shaft of humerus and the fracture at the proximal one-third of humerus. So, in this kind of situation, most people find it difficult to comprehend within these two casts of the proximal one-third of humerus and the shaft of humerus. So please, can you give us some knowledge and guidance concerning these two fractures and their management?
So, as per what question was asked, we have two methods of treating fractures, and which are the conservative method and we have the surgical method. I'll be talking about the conservative method and for the humeral bone. So when we're talking about the humeral bone, it can be divided into three aspects. We have the proximal, we have the distal, and we have the shaft. So when there's fracture to the shaft of the humerus, the best method of treating it conservatively is use slab. Then when we're talking about the displaced proximal one-third of the humerus, what we use in treating it conservatively is the hanging cast, and which starts 2 centimeters below the fracture site, and with a weight. And that weight the purpose of the weight is to serve as a pull so that the bone fragments will be in alignment together. And so that's what I can say about it.
Okay, before we move away from that, let me ask this. You said if there is a fracture at the distal one-third of humerus and the fracture is displaced, we use hanging cast. What if we have a patient that is presenting with that same fracture and it is not displaced? Is there any management for that?
If it's not displaced, what we also use in managing it is the use slab.
All right, that's a very good one on the management of humeral fracture. Thank you very much for that. All right, let me ask the second question. My second question goes to you, sir. And this question is all about the vertebral bones. Okay. Vertebral bones in particular. So there are some people that will say vertebral bones are 33 in number. And we have some other people that will say vertebral bones are 26 in number. So this has been issues where we're contemplating of this thing, and people were bringing ideas. Okay, it's 36, it's 33, it's 26. So how can you do justice to this aspect? Is which of the two are correct or is correct? Definitely.
Yes, talking about the confusion between the vertebral, the 36 and the 33 and the 26 vertebral bone. In some textbooks, vertebral bone is 33 in some, and in others they are 26. Why? In some textbooks they will tell you cervical bone is 7, thoracic bone is 12, that's 19, lumbar 5, that's 24, sacral 5, that's 29, coccyx 4, that's 33. But in other textbooks, they will tell you cervical 7, thoracic 12, that's 19, lumbar 5, that's 23, no, that's 23, sorry, 24, then coccyx, sorry, sacral, they make it 1 because they are fused together, 1, and coccyx also 1. So that makes it 26. So that's where the confusion is. Even normally, they are actually fused together, but in some textbook, they count it as 1 to 5. While some textbook count it as just 1. So that's...
Okay, thank you very much, sir. So in short, we both are correct. Both of them are correct. So you either have 26 vertebral bones or 33 based on explanation and the exposure. So that's a very good one. That's very good one. That's very good. All right, my next question goes to you, and I'm still on the aspect of humeral bone. So if we have a patient, or what are the knowledge we need to get on this aspect where the head of humerus leaves the glenoid cavity of the scapula. So when we have a patient like that, or as a student, what are the knowledge they need to get concerning the removal of head of humerus from the glenoid cavity of the scapula. So when we have that dislocation, total dislocation, what are the things you're going to do? Is there any conservative management for that kind of issue?
Yes, there is a conservative management for that kind of fracture, and what we'll use is soldier spica. And this soldier spica, it's a cast that includes the arm, it includes the trunk, and it includes the shoulder. So it's what we'll do is that after reduction, then you start your application from the knuckle. Then you immobilize the elbow joint, you immobilize the shoulder joint, and it gets to the trunk of like above some centimeters above the trunk. So that's the indication. Sorry, that's the management we give to that kind of fracture.
Okay, that was a very good one concerning the management of humerus in regard to the dislocation of the head of humerus. Okay, my next question goes to you. There's something called toe plates. People have been talking about toe plates, and some people don't get the understanding, and some people don't know it. Some people that knows what the thing is for, they don't know the repercussion of not using it. So what I want to ask is there any way you can help us divine that thing called toe plates and tell us the benefit of using toe plates in management of fractures?
In management of below knee fractures or below knee bones, like actually toe plates, we will use toe plate when we are applying boot casts, and now some other people, so let me say some people do say below knee cast. Let's just put it that way. When you're applying the below knee cast, one is for fracture of maybe medial malleoli or lateral malleoli. One of the can be fracture of the calcaneus, navicular, talus, and so on. Fine. Including toe plates is just us following the principle of immobilization. And another thing I would say is when applying a below knee cast, we do apply it for sprain of the ankle or strain of the ankle. But if you are applying for fracture of the malleoli, either medial or lateral, either fracture of the tarsal bone, either fracture of the metatarsal bone, either fracture of the phalanges, we must include toe plate. It is very, very important because we have a principle in immobilization which is immobilize the joint below and the joint above. The toe plate will allow the metatarsals, the tarsals, and the phalanges to rest, and whereby they will not be able to move. Even if you are telling the patient that give this patient a passive exercise you can instruct the patient to do, or an active exercise, they can only dorsiflex the phalanges. They cannot plantar flex it.
Yeah.
So it is very, very important to know when and when not to use toe plate. If you are applying for sprain or strain of the ankle, well, you might ignore toe plate. But if it is for any fracture, like my medial malleolar, lateral malleolar, tarsal bone, metatarsal bone, phalanges, toe plate is very, very important. To get your accurate results, you need toe plate.
Okay, thank you very much, sir. Let me ask you a question there, because I've seen different casts, management. Even some people will do hip spica cast, be it unilateral or bilateral spica, and they will still include toe plate. Some people will do above knee, full leg cast, and they will still include toe plate. Those people, are they just fulfilling all righteousness, or there is something they are putting the toe plate, or they've seen it as tradition that, okay, let's just add this to that aspect?
So let me say they are fulfilling all righteousness. And as a matter of fact, any cast, like for example, you said the hip spica, unilateral or bilateral, full leg cast, you must include toe plates. Because there is no okay, let's, for instance, you didn't include toe plate for an hip spica or full leg cast. The patient is a very stubborn patient. Let's just say pediatric patient that will go outside with that full leg cast and say, I want to play ball with it. You know, it can actually add some damages to the joints and to the bones itself. So if we include toe plates, and it will even help in the mobilization of the patient, maybe when the patient wants to move and okay, feels I'm not wearing a shoe, and it will serve as a protection for the phalanges to rest the phalanges. So you just serve as a rest for the phalanges. So it helps a lot. So if you are applying the hip spica, bilateral or unilateral, full leg cast, boot cast, we must include toe plates.
Wow. So thank you very much. For the two things I got from that teaching now is that one of the things we use it for is just to follow the principle of mobilization, so as not to immobilize the joint below and above. And the second one is to rest the phalanges, so that the patient will not be having problem for the comfort of the patient. Thank you very much. That is a powerful knowledge concerning that. All right, my next question is, I've noticed some casts in the body, and we have different casts for upper and lower extremity, and I just want to have that knowledge, and people, our viewers all over the world, to have that knowledge. Is there a way one single cast can serve more than one fracture? So if there's I just need to mention, just ordinary mentioning. So is there a way that we can have one cast like this, and the cast is serving more than one purpose? That is, the cast can serve more than one fracture. The same cast, the same application, the same position. Is there a way that a cast can serve more than one purpose? If it is yes, just tell us the names of the casts.
So when we're talking about casts that serve the same purpose, like we have them in theories. We have Smith, we have Montingia, and the Galazin. And these three casts, what they are for, like the bones that they are meant for, are still the same bones. Like the radius and the horn are just like their indications are different, but they serve the same purpose and they are applied the same way. Thank you.
So that's a very fantastic one. That means the management of Smith cast, the management of Montegia and Galeazzi cast is the same. So if you have a patient now that is on that cast, we won't judge at the first sight. We have to go through either X-ray or patient folder or ask the patient questions, because seeing the cast alone and judging by the cast appearance may not be Smith fracture most of the time. So since the Smith cast is one that we are going to use for Montegia and Galeazzi, so I think that's a good knowledge for viewers at home and students as well. So my next question will go to you. There has been some issues that we are contemplating on as regards some bones in the body. A typical example of it is the ribs bone. You know, ribs are flat bones. And we have some people talking about the division of these bones, and they don't understand what they're talking about. So they say, okay, ribs is divided into three. We have true ribs, false ribs, and floating ribs. So why are they calling them true ribs? Many people will know it, but they don't know the fact of what it's made of. So are they saying the truth? Or the false ribs, are they lying? Or what's the context of that definition they give to them? And the one that is floating, do they have birds, wings to fly? So what are the chemistry behind these definitions?
For the ribs, they are divided into three, like my host said, true, false, and floating ribs. The ribs are attached posteriorly directly to the thoracic vertebra, while anteriorly they are attached to the sternum. Why they call some the true ribs are because some are attached directly to the sternum through the costal cartilage, while some are attached indirectly to the sternum through the seventh costal cartilage, while some are not attached anteriorly to anywhere. So now I will divide them from rib 1 to rib 7. They are attached directly to the sternum through the costal cartilage. That's why they call them the true ribs. They are called the true ribs because they are attached directly to the sternum through the costal cartilage. The false ribs are the ribs 8, 9, and 10. Those ones are attached indirectly to the sternum. So the 8, 9, and 10 are attached to the 7th rib.
So they are not directly.
They are not directly. They are attached to the 7th rib. So that one now take them to the sternum. That's why they call them the false ribs.
They don't have
a direct connection with the sternum. So now the floating ribs are the 11th and 12th. They are only attached posteriorly to the thoracic vertebra. They are not attached anteriorly to anywhere. So that's why they call them floating, because they feel they are floating. Anteriorly, they are not attached to any bone and any cartilage or even anything. They are just floating, but posteriorly they are attached. So that's why they call them the true ribs, the false ribs, and the floating ribs. Thank you.
Oh, that's a very good one. So we have the division now. The true ribs, they are true because they have indirect attachment
To the sternum.
and the false ribs, they are false because they have attachment to the 7th ribs. And the one that are floating, they don't even have any business to do with anybody. So, but every one of them attached posteriorly. So that means the 12 ribs attached to the 12 cervical vertebrae.
12 thoracic vertebrae.
Sorry, 12 thoracic vertebrae. Thank you for that. So the 12 ribs are attached directly to the 12 thoracic vertebrae at the posterior aspect. But at the anterior aspect, some of them are attached to the sternum and some of them are sternal. So that's a very good one. That's a very good one. All right, so my next question is going to be a very interesting question, because management of fractures, now we say, okay, when fracture happens, we use POP. When this happens, we use POP. When this happens, we use POP. Are there fractures in the body that when people have them, or when patients sustain some of them, they don't need POP? You know, POP has plaster of Paris, Scotch cast, and some other method of managing fractures conservatively are one of the things that we are sure about, that these are ways we have management of fractures. But are there some fractures that when they happen, we don't even need to go for POP? And if there are those fractures, what are the things we can use?
Okay, yes, there are fractures that we don't need POP in treating them, and the likes of the clavicle and the skull. So when it comes to clavicle, what we just use in treating it is figure of 8 bandage, and there's a way you apply it, being a keyboard position and in a sitting position and all. That's for another time. Then when it comes to the skull, we use carpalin bandage in treating it. So those fractures, even without applying POP, what we can use is just bandaging and it's healed. So thank you.
Oh, so that means there are some fractures that we don't need POP. If not because of time, I would have asked our guests to go more into that, but it's a story for another day anyway. It's a story that we're going to major on another day. So just have that two mindsets, that fractures of the skull and fractures of the clavicle don't need POP. It's a very good one. All right, thank you very much. My next question will go to you. POP scotch casts, they are for management of fractures. But is there any modern ways? Have we been getting some modern techniques of holding fractures that are not even POP, that are not even scotch cast, or the ones that we know? Is there any modern way of managing fractures that are just coming now?
That's actually a very technical question. Although there are materials that are being used now for fractures, except for POP, fiberglass, scotch cast, and so on. For example, the osteoid cast. It's a 3D printed cast. Osteoid cast. Yeah. It's a 3D printed cast, and it's very, very, very good for management of fracture. In fact,
it's not like all this POP.
It's not like POP. It's not like it's a film fitting orthopedic cast that is very designed with the structure of the patient. The designer, POP, you just get your bandage, scotch cast, you get the bandage and apply. No, this one you cannot apply like that. You have to get the film fitting of that patient.
So they must have measured that.
They will have measured the patient. Now, with this fits the patient. So after measuring it, they will now use a 3D printing to print the cast. We call it osteoid cast. Osteoid medical cast. So we use that also. And it's a very, very good, but very expensive. And as a matter of fact, it's not really much in Nigeria right now. The last time I checked, it is kind of very expensive, like $200 to $500. Imagine the patient, you told the patient to pay $200 to $500 in Nigeria now for an osteoid cast. The patient will just tell you, is the osteoid cast having the same purpose as the POP and the scotch cast? If yes, let's go for POP or scotch cast. But the advantage is that it has ultrasound technology that helps in the healing of the fracture. It helps the fast healing of the fracture. So it's very, very good. But for now, it's not really much in the country, except for developed. Our country is a very developed country, but we know there are some countries that are above us. Yeah. So it's in other countries. But right now in Nigeria, and we have the HM cast also, which is also very, very good, but it's expensive too. But right now, we are still down with our traditional POP and scotch cast and fiberglass.
Oh.
But there are other materials that can be used for management of fracture. Thank you.
Thank you very much. That's a very good one. That's a big knowledge. We are expecting them. Although they are not readily available now, but we believe in some years to come, we'll be having the likes of what you said, osteoid medical casting, active armor casting, all those things. We have them, but it's very expensive. Yeah, that's a very good one from you, sir. My last question for you: the longest bone in the body is femur, am I right? So that is what everybody believes. So we need to get the idea or the knowledge about the shortest bones in the body. Are there some set of shortest bones in the body we have, and where are they located precisely?
Yeah, we have the longest bone in the body, which is the femur, and when we talk about the shortest bone in the body, we have the malleus, we have the incus, and we have the stapes, and these particular bones are found in the ear. So most people don't really know it, but it's just like it's not common. And sometimes we used to ask that, is there still bone in this ear? Or yeah, and they are the shortest bone in the body.
So we have bones in the ear, malleus, incus, and stapes. These are the set of the shortest bone we have in the body. All right, that's a very good one. Thank you very much. Thank you very much. All right, my last question for you, sir, before we put anything to close. In the management of fracture, you said something the other time that we need to follow the principle of mobilization.
Yeah.
By mobilizing the joint below and the joint above. Now, there is a fracture, there is a cast in the body. They have studied that cast very well. Most people do 3 joints mobilization. Now, and that's hip spica cast. In hip spica cast, in most cases, we mobilize the hip joint, we mobilize the knee joint, and we mobilize the ankle joint. Normally, the way we should do it is immobilizing the hip joint and immobilizing the knee joint. So the cast to stop at maybe 2 centimeters below the malleoli. Some people used to do it that way, but it's not common. Yes. So those people that follow these 3 joint steps, what are the reasons behind that application? Is it that they are just interested in wasting cast or wasting POP materials?
No, for those that are following the 3 joints management of hip spica, the 3 joint application of hip spica, they are not wasting materials. That's one. They are not wasting the materials. They are not wasting the patient's resources. Following that is, in fact, they will get the accurate result they want to. For those that are applying below the ankle joints, well, they will still get their own result also.
Okay.
But it might not be as accurate as those that are applied using the 3 joints. Immobilizing the 3 joints. Why? Fracture at the femur involves large muscles, especially the hamstring muscles, and they are very, very large. So if we are to immobilize and we have to do the hip spica, we need the 3 joint, the hip joint, the knee joints, and the ankle joints to be immobilized in the cast. Why? If we did not immobilize the knee joints and the gastrocnemius muscles are moving, if any movement at the gastrocnemius muscle will affect movement at the hamstring muscles. So, and when it affects it, it might displace
the fracture.
So when it displaces the fracture, the management might not get the accurate management, and the patient might have a relapse, because that's when you can have malunion or non-union. Which will now lead to delayed union in it. So now we need to involve the 3 joints. So now, if we immobilize the ankle joint, the knee joint, and the hip joint, no movement will occur. So the fracture will heal without disturbance. But if the ankle joint is not immobilized, mostly these days we apply hip spica for pediatric patients most of the time, and they are very, very stubborn and they want to play. So now imagine the pediatric patient that you apply a hip spica for, and you don't immobilize the ankle joint. You might feel, I can use this leg to just play around. And while playing around, the gastrocnemius muscles are moving. So it's better to use the 3 joints, to immobilize the 3 joints in hip spica. Thank you.
Oh, that's a very good one. Thank you very much. I want to appreciate the 2 guests, the speakers I have here with me today. Honestly, you have done many, many things here today, and I really appreciate you. I really welcome you to this channel. I celebrate you. All right, to our viewers at home, I believe you've had a great time with us from our respective speakers we brought to this channel. So you are free to go over this channel again, just get through some things and just try and understand what it takes to manage fractures conservatively. All right, guys, that will be all for now. Feel free to watch over the video again, and don't forget to subscribe, don't forget to like, and don't forget to share. And if you have a question, just put it in the comment section, so we attend to it. And it's a very lovely time with you guys. I celebrate you, and we will not be too proud to have you again in our next production. All right, guys, that will be all for now. See you in the next class.